Um, Please make sure your audio is muted unless you're speaking. We will be using the chat feature. You can ask questions, answer questions, make comments, or offer information. Please feel free to also unmute yourself and ask a question at the end of each slide or when the consultants prompt that. If you experience any technical difficulties, you can message me either in the chat or you can email me at mbenson@bhnstl.org. Also, this will be recorded, so just so you are aware. So at the end, I will be sending this out in a couple of days. And at this time, I'm going to pass it over to Sally, and thank you.
Thanks, Melissa. So my name is Sally Haywood. I'm the Senior Director of Strategic Initiatives for the Behavioral Health Network. And we are a planning coordinating entity for the Eastern region, St. Louis and surrounding counties. And we are thrilled that you're here. Thank you. Project BEACN is a initiative where we're looking to cultivate systems change for individuals with complex needs. As we all know, there are clients or patients who receive a myriad of services, but don't retain the gains hoped for from those services. So we need to refine our approach and our collaborative attention to serving them. And this all evolved out of a visioning process that BEACN participated in over the course of a few years, a little while back. We're currently funded by the Missouri Foundation for Health to pursue this work, and that enables us to engage consultants from the Camden Coalition. So I'll pass it to them and they'll introduce themselves. This is Melissa and me, and of course we always welcome your comments. Next slide.
Hi everyone, I'm Lauren Hardin. I'm Senior Advisor for the Camden Coalition's National Center for Complex Health and Social Needs. I'm a nurse by training, but a data geek at heart. I'm so excited to talk about this topic today. What I found in my work with complex populations, I've been a clinician directly providing care, starting more than 15 years ago, with direct care with homeless populations, serious persistent mental illness, very frail elders, kids coming out of the foster system, pretty much every population. And what I learned is that metrics, data, and evaluation are one of the most important components of the care that I was providing. Because if I had a good infrastructure of the metrics and the evaluation, I was perpetually able to advocate for investment in the important care management, the important process improvements, the important system connection that needed to happen to really change things for the population. So we're so excited by the work that you're doing in St. Louis. You're already ahead of the curve. We work with people around the country, and we're very excited to work with you on the next phase of where you're heading. Jason?
Thanks, Lauren. What a great group here. I just, a special thanks to Sally and Melissa and Wendy from BEACN for their ongoing leadership here, especially in trying times as, you know, we were kicking off this initiative and COVID hitting. So just super impressed with what they have put together and organizing this group, and to all of you for carving out time for us right in the middle of your day. And many of you have been on multiple of these. We have done, we've done 5 of these sessions over the last 5 weeks on different topics and goals directly related to Project BEACN. And this one we're especially excited about. It really ties into our, definitely a core domain that we work with groups on across the country. So my name is Jason Turi. I'm a nurse just like Lauren, and have the privilege of working on the Camden Coalition's National Center team. We have a local clinical operation in Camden, New Jersey, and we're going to talk about that today and some of the research and evaluation that we've done. We also get to work nationally with organizations, consortiums, collaborations, just like yourselves, focus on high need, high risk individuals and populations. So as Lauren was saying, we're going to focus this conversation on metrics and evaluation, down to the individual level. Also talking about how we weave that into our programs, especially in the challenges of a complex care paradigm. Really focuses us to think about how we use data across organizations and across sectors. So without further ado,
Hey there.
jump right in. Go. Hi there.
What you up to?
Hello. Just to remind everybody, you can certainly, if you have a question, please chat us. We'd love to see you on video as well. And we'll jump right in here. Okay.
You're muted, Jason.
It muted me, sorry about that. So the purpose today is to really dig into metrics and evaluation and talk about national trends, talk about the experience that you all are having as well. So this will be participatory, and we will be encouraging you to participate from your perspective. We're gonna get into the weeds on what metrics are valuable to our organizations and our stakeholders. What are the different methods and intent around evaluating, and how do we tie that to the programs and to the populations that we're trying to impact? So so we'll walk through the agenda here again, looking at complex care, looking at how to frame an intervention for evaluation, looking at an outcomes framework that we think could be really useful to you, and that some of you, we'd love to hear your feedback on that. And then discussing your regional initiatives that are currently underway, indicators that are top of mind, and data sources that you already have access to. And then we'll talk some next steps. So like I said, your participation is key. So we know it's challenging. We're living in a Zoom world and everyone is multitasking. But if you could focus with us for your 90 minutes, we really appreciate your time and perspective. Use the chat with us and lean in and give us your perspective. That will just add to our experience here for the next 90 minutes. So with that in mind, we would love each of you, in order for for a roll call, to use the chat function. Please put your name, position, and organization in the chat so everyone can recognize who is here. That'll be super helpful. As we're recording this, that'll also be available as well to us as we go back and review the chat and the information that's put in there. So please go ahead and do that. That would be very helpful for everyone. Thank you. As you're doing that, go ahead.
I wanted to just reiterate that I neglected to say we get to work with Jason and Lauren over the next couple of years, but we had budgeted for them to do a site visit and meet with clusters of you to gain your perspectives. But given COVID, we are doing our consultant site visit in these incremental meetings, which will culminate into their sharing a set of recommendations and their perspectives for our implementation of complex care work. So really, the more honest you can be around your cares, concerns, priorities, the more informed our work will be as we roll out these efforts.
Thank you, Sally. Thank you for that. And we'll be along for the ride for the next several years.
We really look forward to when we can meet with you in person.
Yeah, absolutely. Hopefully, as we address the pandemic, we can be out there and get on the ground. And we do certainly there's some opportunities, but a lot of challenges. So we will persevere. We'll push through on the Zoom here. And thank you for everybody for putting in their information in the chat there. That's really helpful. We're going to use the chat. Please use the chat throughout to feed us questions. And if I miss a question as I'm facilitating, please, Lauren, Sally, Melissa, just jump in because it's hard to toggle between the chat and the presentation. So, thought for folks that may not have been part of the other discussions, what is this thing called complex care? And we have a definition here in a visual that is hopefully helpful and really ties into what Project BEACN and what a lot of your individual regional initiatives, which we'll go through later in the presentation, are really seeking to impact. Complex care does focus on a small, diverse cohort of individuals with complex physical, behavioral, social needs, many times in the context of significant life trauma and adversity, and how systems of care, or what we would call an ecosystem of care, and you can see what our visual of an ecosystem here would be, can wrap around these vulnerable populations to make a significant impact in their wellness and their quality of life, and the significant individual and community benefit that can happen there. But currently is not, right? And I think we can all agree, you know, there's a significant amount of fragmentation, siloing, and room for improvement, especially for our most complex and vulnerable individuals that we serve. So this is an overview of complex care. Lauren, would you like to add anything before we jump in?
No, I think this has just been really helpful as a graphic. So we know this directly providing care, that the people we serve are impacted by many systems. And the more we think about it in a connected network, and also think about metrics and evaluation through a lens of what matters most to each of the partners, the more successful these initiatives are.
Thank you for that, Lauren. And if we think about it, and this will tie into the next, as we jump into, we're going to do a case study of Camden. You know, this movement is really a recognition that one organization, one sector can't go about this alone. And we learned that the hard way in Camden. You know, very progressive care management program, tried our best to wrap around complex individuals. And it was really challenging to make an impact when there were such significant complex needs happening. So we'll be sharing these slides and we'll share everything that we reference. But just to keep this frame in mind as we jump into thinking about metrics and evaluation for this population. So I'm going to tell you a story, sit back, about evaluating complex care. We were challenged as an organization early on from the Camden Coalition side, which is a community-based nonprofit. We designed a complex care management team to wrap individuals around with nursing, social work, community health workers to try to make an impact to keep them out of the hospital, right? So there was a lot of attention on this program. People really started to hear about our work several years ago in hotspotting. You might have heard of our founder, Jeff Brenner, right? So a lot of excitement, and we engaged researchers to actually do a randomized control trial of our work, right? So this is a rigorous evaluation, and many of you might have, and we will share this article in the, when Melissa sends out the follow-up materials. So researchers, so top health economists in the country and researchers from MIT put together a study with us to look at if what we were doing was actually having an impact, and using an experimental design. And we can talk a little bit about control groups when we talk about measurement. So this article came out in January 9 of this year, made quite a splash, and if some of you may be familiar with the findings, but this represents a very rigorous analysis and very particular type of analysis of an intervention, and definitely falls into the research realm. And we're going to talk about the differences between research and quality improvement.
Can I add a comment there, Jason?
Go ahead.
So I just want to give kudos to the coalition, even though I work there now, at the time when the decision was made to do our RCT, so this high level evaluation. Many programs from around the country who are doing complex care were invited to do the same thing. And at the time I was working for Trinity Health and had a very successful model that scaled there. Many people from California all the way to the East Coast were at this meeting. And the only organization that stood up and said, yes, we will do this rigorous evaluation was the coalition. Because everyone else knew in this kind of heterogeneous, complex population with tremendous challenges and tremendous diversity, how challenging that might be. So the lessons are very valuable that were learned from this. And kudos to the coalition for taking up the challenge.
Absolutely, thanks, Lauren. And so we had they came to our organization and we designed with them. So Amy Finkelstein, although and you can see her name here, PhD, she's a health economist. I took her on a home visit in Camden to have her really understand what we were doing. And needless to say, from a health economist coming from MIT to go on a home visit in Camden, New Jersey, was definitely eye-opening for her. I want to tell you a little bit more about some of the backgrounds of the folks that were actually associated with our program. I'm going to chat it now. these are the folks, so when we looked at the demographics of the folks we were triaging, it gives you a little bit of a hint of the complexity of the population, and I'll chat it for everyone to see, and you can review that if you're curious about what are the types of individuals that we were engaging in this program. So I'll go through and tell you the story of this and where it led us, and the story of the coalition. So, the coalition focuses primarily on vulnerable complex populations, and we're really working towards a transformed healthcare system locally and nationally, and that informs the work that Lauren and I do as well. Many of you have seen this slide on previous presentations, but really these are the challenging minority of individuals that we were focused on for our intervention, and really matches a lot of the targeted work that you all are doing with the populations you're serving. These are individuals not only with high healthcare costs and utilizations, but significant, complex, chronic issues across the board, as we mentioned, behaviorally, physically, socially, and coming from histories of, as I mentioned before, adversity and challenges and trauma. So our model, which links up very closely to a lot of the work that you all are doing, is on the ground work in care team interventions, working with practices to redesign their operations. We run a regional health information exchange with data analytics, and we see ourselves as a convener and work towards policy and advocacy changes as well. And that's part of the work that Lauren and I do in the National Center. It's informed by on the ground work that we have done either in Camden or another work around the country. So our model, which you'll see if you've been a part of these discussions, is infused into the way we look at problems and work through solutions. So just to walk you through here, this is a typical actually workflow, right? So I'll up here when we go to daily triage, this is Molly, who spent a year with us as a pre-med student, and she's triaging the daily list from the local hospitals that come through our health information exchange. Individuals are flagged for complexity and high utilization and risk, and then they're engaged, and you can see Margarita here on bedside engagement, engaging someone directly at the bedside. She's dressed kind of casually for a reason, because she's there to make a connection and really engage somebody about what is actually happening to them and what do they need support on to really align with that individual. The care planning piece here, many of you, if you've been part of our presentations before, this is Michael. Here he is actually doing some bedside care planning, really working with folks to devise a plan of mutually agreed upon goals of what matters most to them, and working towards that to them for as long as they need it. Our intervention, it lasts between 3 and 9 months. It depends on the complexity, and folks would be handed off back into the appropriate level of care. And a core of this are our community visits. And you can see one of our LPNs, Hilda, here, and one of our CHW, Shakira, who's now a social worker, engaging with an individual in his home, who actually gave us permission to actually share his picture with the group as part of his plan for advocacy. So a core piece of it is actually home visits, broadly community visits as well. So accompaniment throughout the community, throughout the ecosystem as advocates, as allies. So that's a little bit about our model, which probably looks very similar to the work that you all are doing. And our wraparound whole person kind of 360 care planning approach, which pretty much tries to hit on anything that can possibly come up as a significant need of an individual. If it's not here, you could always put it in the other piece. I will say, though, that the individuals that have shared their pictures here, and I'm sharing their stories, we talk to them specifically about their advocacy and activism. And many individuals want their stories shared so they can advocate for changes. So we formed a research partnership to test our theory of change and to contribute to the evidence base for complex care, which is an emerging field, right? Certainly when I was in school I'm still in school, but we are charged with codifying a new field here, which really incorporates many different fields. So part of that was being rigorous about our approaches to evaluating what we're doing and capturing the lessons learned, the challenges. So like I said, like Lauren mentioned, we opened ourselves up to really anybody to come in and to work with us to better understand that, even though that presented challenges and risks to our organization. So what was the question that was specifically asked in this randomized control trial? At 180 days, which would be a half a year after hospital discharge, do patients enrolled in our core model experience a lower rate of hospital admissions? And again, that core model was community-based. It started right after discharge from the hospital. Nurses, social workers, community health workers, wrapping folks around for multiple weekly visits, liaisoning to primary care, connecting to housing services as much as possible. Go ahead.
Could I ask you a question about that?
Yeah.
So I'd love for you and Sally to talk about how does the population that you were serving there compared to the population that's anticipated to be served in St. Louis under this project?
Great question. Well, a few things about the folks here. They weren't necessarily coming off a psychiatric discharge, but 90% of the individuals had a mental health diagnosis and may have been admitted before for a psychiatric condition. So as I mentioned in the chat, a significant amount had a substance abuse issue as well, and significant housing issues. Sally, how do you think that and not to mention chronic unmanaged physical health conditions? So when you think about the
population is barely different than we're doing a lot of this innovation and systems change work with the collaborating partners on the emergency room enhancement project, who are 100% referred for having a severe mental illness or substance use disorder and a pattern of high utilization in the hospital. So, and they almost all have a comorbid physical health condition. So it's very, very parallel, but with behavioral health being an inclusion criteria for us.
Mm-hmm. Yeah, that's helpful. So we didn't exclude. We were broadly. We had a group of hospitals, and it was for us the triggering index admission was 2 admissions broadly in 6 months, and that could have been for a psychiatric condition or a medical condition. Most of them were for medical, since that's more the volume. But certainly, folks had very similar. You're right, but there's certainly parallels between the 2 populations. And I would say would fall into a similar risk category. The issue here, and so much of this was done post ACA. So New Jersey did do an expansion of Medicaid. Most of these folks were able to get Medicaid as well, if that plays into it. Just thinking about some of the other factors. But we had a very similar as well in Camden. We had 3 competing health systems that were on different electronic health records. So think about the terrain in a major metropolitan area. Camden's right across the river in Philadelphia. Folks are flowing over there as well. So thank you, Lauren. Thank you for that framing.
Thank you.
Hey, Jason, just a quick question. Relative to the research question and the lowering of hospital readmissions, when you're looking at readmissions, are you the decrease in readmissions, whether that readmission, you're looking at both behavioral health and physical health readmissions, right? Just in general across any type of readmission, or
Correct.
Simply medical readmission?
No, yep, correct. You had it right the first time. They were looking for any type of readmission into the hospital.
Okay.
And that's where, and I'll go back to the slide here. That's where the question was really challenging to him, right? This is significant, not easy to impact this, right? If we think about this kind of broad outcome here, what if someone went back for a planned admission? Again, that was as we started to learn our lessons on how you frame the question and what are the outcomes you're looking at. These things. Mm-hmm. So we were held to task on this, and there was a control group in Camden, just so everyone knows here. There was an intervention group that got our dose. Everyone was randomized into this. So there was a intervention group that would actually be engaged. There was a control group that was randomized that they were admitted for the same criteria to the hospital, but we didn't engage them. And then those 2 groups paired over time. Okay. So just a little bit more about the trial. It lasted 3 years. We had to design this, and we had to engage and enroll individuals at the bedside in the hospital into the program. Individuals, like we mentioned, had extremely high levels of hospital utilization for various issues. Complex chronic physical health conditions, behavioral health conditions. So you name it, it really, it spanned the spectrum of different issues an individual might have. We were continuing to change and refine our model as the trial was going on. So this isn't like you're getting a dose, for example. Now there's RCTs happening of a vaccine, right, for COVID, and that's a dose of a specified compound, right? This model was, we were changing this, we were adding staff, we were tweaking the way we were doing things, and that was because of learnings that were happening on the ground and changes in our ecosystem, right? For example, we recognized the need during this time for more behavioral health support, and we hired behavioral health specialists to be integrated on our team. Also, we were, as an organization, as a fledgling nonprofit trying to make our way, really concerned about financial support. So at this time, we did have stable funding, which reduced the risks to our organization, and some of that did come through MIT and supporting us through this. So the answer: care management alone cannot remedy lifetimes of complexity. Essentially, we had a null effect on what we were doing compared to the control group. So it really forced us to think deeply about, what could have been done differently here, right? Maybe, and to the question before, was the research question a bit, was it really focused on what we were doing? Were we really fighting an uphill battle, trying to really to solve or ameliorate like lifetimes of challenging issues within our 6 to 9 month intervention? And it really focused us to think about, what are the solutions that can be brought to bear? And certainly our work nationally and with BHN here regionally in the St. Louis area speaks to that, the idea that one valiant program can't do it all. There's way too many needs being presented in this population for any one program to solve. So here are some of the results at 180 days, that there were similar readmission rates between control and intervention groups. One of the positives that came out is that SNAP, which are food assistance benefits, rates were actually increased. And you would expect that, especially if, as we went through our comprehensive assessment and we asked folks, are you tied into, are you receiving these benefits? You might be eligible, and really thinking, we tried our best to wrap them around. And this was one of the outcomes here. So this actually made quite a splash nationally. Our program was seen as cutting edge, hotspotting, using data and wrapping around with this aggressive intervention. And there were headlines: Camden Coalition, intervention doesn't work, care management doesn't work, care coordination doesn't work. Some of the headlines were really tough for our staff and our partners, or even our patients and advocates to take. We began thinking about ways to cut the data in a different way, looking at different outcomes. But really the main outcome that they were looking at was, between these two groups, what were the 180-day readmission rates? And that was really it. So so that's what they held us to. And it was a tough pill to swallow, but again, we did our best to learn from that. We think within breaking down the groups even more, that as we do our secondary analysis, there's certainly insights. I'm actually involved in a project of really looking into the charts and experiences of the individuals that we did have an impact with. Many of those, interestingly enough, are complex. They have behavioral health and social need and significant social needs that we were able to make an impact. But again, no shortage of challenges that way, and really trying to think about lessons learned and incorporating it into a system-wide approach, as we're doing here with our work in the greater St. Louis region. Other measures and analysis, they didn't measure programmatic goals, which we think are important, and we'll advocate for that, certainly as we talk about our framework. And again, as I mentioned, we're digging deeper to think about what were the areas where we could have gotten better, especially for folks that present with a significant mental illness. We know that impacts their functional limitations and capacity and ability to manage other aspects of their lives that would have been helpful in their longer term stability. So the work continues, and it continues with partners like yourselves here in St. Louis in ways to figuring out how do we best meet the needs of these populations as stakeholders in an ecosystem of care. So again, the work continues. We're still running our programs in Camden and working with partners nationally to apply lessons learned and to continue to advocate for kind of robust system level changes that will impact these populations. So we're all in this for a good reason, and it's not easy to take results that look negatively on your organization. It takes guts to be transparent, and we've seen we work with groups nationally that have had to go through similar growth experiences. And as we think about metrics and evaluation here, there are going to be places where all of your organizations are going to need to improve on a continual basis, and having the guts and transparency and the culture that supports that is really important. And we've seen a lot of that here on the ground in St. Louis, and I think Lauren would agree that you guys are really primed to kind of step up and implement your programs, or you're implementing great programs, and apply rigorous evaluation methods to see, hey, what are we doing? Is it working? How do we make it better? And how do we demonstrate value to our stakeholders? So again, you've seen this in our approach here. We really push for a cross-sector ecosystem solutions to a lot of these problems. Community resources are key. Linking those community resources is really important. Just like we're doing here with a group here, convening communities into collaborations such as this through Project BEACN and Clinical BEACN, and the various other the high utilizer programs that are ongoing, and listening to the needs and building them back into the designs of these programs. So
just to make a comment here, Jason, I realized one thing we didn't say on the front end. So even though we have a very well recognized model in Camden, our team also has been involved in implementing and designing different successful models around the country, because we came from different places as well. And now we work with sites around the country, co-designing models that make sense and fit in the community and the problem that community is trying to solve with the resources. So I want to make clear, we're sharing this story with you to share some of the really important things we learned that can help inform your evaluation. And we also have worked with many sites around the country solving a different problem using different data and different outcomes that were successful. So we're happy to share all of that with you. But the key message is learning from some of the paths, but what we're looking at doing here is really co-designing what will work the best for your community rather than landing a model on your community.
Absolutely. Thank you, Lauren, for that. And that's part of, we're asked a lot of times, well, what's the model, right? Well, there isn't one solution here. And here are some of the reactions of some of our staff and advocates. And I think we even added a individual client perspective here. The one that really stands out to me is this one here. Nothing works overnight. Everything is a process. Building people up who have mental health issues, spiritual issues is a process. So, hopefully that can reinforce us as we go forward. The work is challenging. All of the components that we've talked about, the key goals in this program, whether it's metrics and evaluation, aligning your health systems and data, really deeply collaborating, are all challenging to do. And we find ourselves in the middle of building these things as we're going, right? There's no one magic pill or app that is going to kind of move us forward. So with that said, I'd like to go into how we begin to frame and plan out an evaluation. I'll also leave a moment here before actually going on. Any comments, anybody after that story? Does that resonate with any of you all? You can feel free to jump in on the audio, and I'm just getting a chance to look at the chat here.
I was just about to say, Jason, there's a response to the chat, actually.
So it's a great question about how long it took to get the reduction and then data from the other models around the country. So, we have this great opportunity working around the country to be informed by this experience. So when we're co-designing models on the very front end, we build the framework around what metrics will they track, what evaluation method will they use, and Jason's going to go into the specificity of some of that, and then set up pretty rigorous data tracking on the very front end. What we see in many of the models, so it depends on the population they're focused on, what they're trying to do. But there's multiple articles we can share with you about those models that many of them, we'll see impact right away. So in the first couple of months, because the population's been very underserved. One of the tricks about the RCT is it's just looking at readmissions in 180 days. We recommend people look at more than just readmissions, and that they capture multiple metrics that make the case in multiple directions for different stakeholders. But we often see reduction pretty quickly if people have a good design in what they're doing in the program and are integrating social determinant of health interventions right away. And also have pre-designed links to some of the services and gaps that the person isn't receiving. Would you say the same thing, Jason?
Yeah, and I think and thank you for the question. And Lauren, there's that immediate, like, you're right, there's that immediate reaction. There's also the statistical notion of folks regress to the mean, like, very quickly, they've had their acute utilization and it kind of goes away. This is kind of the issue, like statistically, with a pre and post analysis, right? With the control group, right? That folks they'll have their utilization, then it'll fall off. And think, oh, we're doing something great, but it would have happened anyway. And that's a lot of what was at stake in the RCT. So really getting an understanding and applying a method that really is rigorous, and we'll get into this too, that is, what is the intent too of the evaluation as well. There's different approaches that way. So I appreciate the question. And also I would add too, this is emerging, right? So you have a lot of smaller initiatives happening across the country, right? That we're privy to, but it certainly isn't the mainstream yet, right? So our function as a national center is to kind of pool all of these innovations, challenges, folks that have tripped up in their, quite frankly, in their implementations, learn from those lessons. Certainly incorporate the lessons from Camden as well. So this community is growing. What's been cool about BHN's participation here is including the work that's going on here into the national conversation around emerging this field to impact this population. So
and I'll put links in the chat to a few articles too that you can look at for other outcomes from models that we've done, and while Jason's doing the next.
Yeah, of course. So let's talk about framing and planning your evaluation. And this will look different for every group. Now we're going to go through later on and talk about some of the specific interventions happening across the region. But Lauren and I wanted to take some time to like slow down a bit and say that not everyone has to do a randomized control trial. We wanted to use that as an example of that's a pretty rigorous and may not be the best thing to apply. There's certainly lessons there around rigor, around design that uses a control group. But there's different approaches to evaluation. Certainly research fits one specific area, and many of you might be involved in a research protocol of your intervention. When we scan the list, I don't know if there's many of you doing that, but there's certainly, that certainly is an option. But we think many of you would probably fit into some other categories. And I've grouped these, and there's crossover here with some of these, especially with proof of innovation effectiveness and continuous quality improvement. The idea that you're working through cycles of improvement and innovation, and you're trying to measure that and account for that and evaluate that, we think fits more into this, into the categories of the interventions we're talking about here. Ultimately, I tied it into a financial component here because very quickly, when you talk about the funders and stakeholders of these programs, they want to know, is there a return on investment, which is a mix between, is there effectiveness clinically, that also, and is there effectiveness financially as well? Lauren, do you want to add anything specific here?
Sorry, I was copying links. Let me come back. I'm introverted. I can't do two things at once.
Oh, no problem. I think what we
yeah.
wanted to tease out was, and you've seen this, much of the work that we've done with the groups around the country has focused on, establishing a use case for the effectiveness of innovation, right? Really building quality, continuous quality improvement cycles into the operations of the work that are happening with each program. And then eventually working towards working towards a return on investment equation that can be used to make the business case.
Yes, and so having worked around the country and also just having defended or really done a lot of the work around getting people to sustainably invest in these programs around the country, I'm always advocating for an ROI evaluation on the front end so that people have what they need for a continual investment. With the research component, on the other side, my recommendation typically is you need some time to iterate and get your model to land before you do a full-on research evaluation. And I think that that's important. The CQI component's really important. Rigorous and clear data that you're tracking from the front end is really important. We've had the privilege of being in this field a long time, making mistakes, and we can share them with you so you don't have to waste time making them and can pick some really valuable measures right from the front end that target what your stakeholders care about most. That will save you time. It will give you the data you need for the perpetual investment. And then I think you can get to the point of doing the research. So I'm curious what you think.
Yeah, Lauren, can I pose you a question from Barbara and then I'll answer it as well?
Yeah, yep.
Program design direct what the evaluation components should be.
Definitely. Can you say more about that, Barbara?
Yeah, I just thought that what you just said about really landing on the design before you really can understand how to evaluate is going to be something that I thought would be an important part of the conversation. So you brought that up.
Great. Yeah, I totally agree with you. And Jason will show some of the things that we recommend that you track to help inform, a more rigorous research type evaluation later, but also to gather that data that you need to inform iteration in your design, and then also to inform that perpetual investment from your stakeholders.
Mm-hmm. Barbara, thanks for the question. And I'm thinking about, so if your program is designed, I know that there's programs in the region that are designed to link individuals to housing, right? So certainly housing as the goal, as the end goal of okay, a major output of this should be folks that present here are unstably housed, and afterwards they'll probably be stably housed, which is great as the kind of the big goal. But I'm also thinking about, and we talk about this, and something that was missed in the evaluation from Camden, all the programmatic, all the process measures, or even some process/outcome measures that kind of ladder up to that can be a part of that, right? Also thinking about what are the other benefits of getting someone housed that aren't necessarily captured in your program. And that really forces us to think beyond our organization. And we talk about this idea of community benefiting other systems, other organizations, indirectly, directly. We talk about upside in our presentation previously a few weeks ago. We talked about how there's upside risk to some stakeholders and downside risk to others, and when with the same intervention. So I appreciate the question there. And we'll go into the framework of some of the kind of the holistic measures that we can apply across interventions, which I think will be helpful. So our next component here, and we definitely want to hear from you, and we'll leave some time at the end of this conversation, is where's the data? And some of you may just be relying on your own organizations for data, but if we go back to the definition of complex care and working across sectors, across the ecosystem or continuum of care, across a community like yours, there is information that could potentially be useful to validate your intervention that doesn't necessarily live within your program. So if you think about Camden, think about how we were able to tie into the idea of folks that were eligible for SNAP benefits were actually you know, assessed and enrolled in that program. That wasn't something that we were really even measuring, but actually came up in the evaluation. So here are some of the different areas that some of you might have access to, and we want to hear from you all. If you are working with any of these data sources. So some of you are community-based organizations and you have your own data, and that's great. Some of you are tapped into other areas where you have information that can enrich your evaluation. So, for example, large foundations actually have, and many of these are health, or behavioral health related. Although there's certainly challenges in sharing individual level behavioral health data. Trade associations, like the Missouri Hospital Association, we've been having discussions with them. I'm not sure if there's any insurers or payers on the line here, but a rich source of information, especially claims information. And many payers are very willing, especially if there's established relationships, for example, in value-based care or through provider relations, to share information. Very typically, for example, that would, one of the typical things that a payer would share would be a gap in care report for attributed members, and that can help enrich your data. So the point here is that, and we talked about this on our previous data discussion, there are rich sources of data across the community, but it's really connecting with those as well. And there are no shortage of hurdles in getting the right data to enrich your evaluation. Lauren, do you want to mention anything else here?
No, just that this is a great step to define on the front end. And the principle is, what is the easiest way to get the data where it's legitimate and clinicians are not trying to track this by hand.
Yeah.
And that you design it on the front end, so you're collecting it from the front end rather than trying to retrospectively pull it out of records or recreate it. And we definitely work a lot with sites to help them do that well on the front end and identify the sources where you can hopefully pull automated reports on your population.
Thanks, Lauren. And I want
got,
to call out Meredith. Go ahead.
Yeah, and I call out Meredith, please do. And we've also got Dr. Rhonda Brown, who works for Healthy Blue Mo Anthem, and they're mentioning of claims and social determinant of health Z codes, availability of payer data.
Yeah, and that might be a new concept for folks. I'll let the folks at Anthem, if they want to hop on, kind of explain like what these are. It might be helpful. If not, I can certainly go through it, but I want to give the folks at Anthem, which is a payer there in Missouri, they're part of this call. Would you want to add, Meredith?
Sure, although I did see, so Dr. Brown is my supervisor, and when I saw her unmute, I said, oh, okay, well, I don't have to speak on it. I'll let my boss go ahead and elaborate. I'll give you,
you are more than happy to do so. Thanks. Go ahead, Meredith, please.
Sure. A condensed version of it is what we see as, well, I came from the not-for-profit world, and so community-based organizations is, that is a lot of where my experience lies, and that is what they are. They're social service providers in our different communities, connecting people with resources. Social determinants of health are those resources, or that's the name that is currently and often being used when they're referring to social services. Which are everything from utility assistance, housing, shelters, things of that nature. Z codes are the medical codes that are used, that are associated with those social service resources. And as Jason has stated, they're fairly new when it comes to the utilization of the Z codes. They are primarily used by providers on claims. So although providers do not get paid for those claims, it helps to tell the story, and it helps and assist a provider in giving them comprehensive care. If someone comes to you, for example, and as a provider, and they are repeatedly coming to you for an issue that could potentially be something that could be addressed by addressing an underlying issue that is not medical or clinically related. it is a social determinant of health or it's a social service resource, then that provider may list that on the claim as a part of what they've identified with that visit. And again, that'll allow the provider also an opportunity to reach out or either provide that person with some resources so that can be addressed, and maybe we can either eliminate that is presenting itself as an issue, or that can also curtail some of the repeated visits if it's housing, for instance, and housing is an issue because you're couch surfing. If we can get you some housing, then maybe now we can begin to, and it's not an issue of compliance. I'm not very comfortable with the terminology of compliance. People are, not always non-compliant, but it is how they prioritize what is most important as they figure out what they're going to do with their day-to-day existence. And so it's not always, I don't want to be compliant with taking my medication for the asthma diagnosis, but not having utilities on at home is taking priority or taking precedence over what's going on with filling that prescription for my albuterol. So I'm going to do first things first.
That's so important.
That's all I have.
And just to piggyback a little bit on what Meredith has shared, as a health plan, what we've begun to do is to establish several initiatives in which we can better partner with our providers to encourage and promote the utilization of the Z codes, so that then as a health plan, we can deploy our social determinants of health team as well as care management teams to be a stronger support, so that those issues are no longer a barrier for folks getting and maintaining a balanced state of health, a more balanced state of health than what they have been able to do. So
That's great. Anybody else want to comment? We're so excited to interact with you. We can't wait till we're there in person.
Yeah.
So.
Lauren, I'd like to just like a clarification on. I think the Z code issue is really helpful, and especially our community-based organizations that are online, especially the community mental health providers. Many of them are very close to the action of social determinants of health. They're billing through Medicaid, and here's my guess: many of those codes aren't being captured because they're not part of the workflow. Maybe there's not an incentive there. For the folks at Anthem, I'd just like to hear, and what is the thinking about trying to capture those, incentivizing those activities so we can better understand, you're right, the needs of the members, and incentivize intervention.
So we started taking a look at this issue probably just a few months ago to just get a baseline for within the market, how is there utilization of the Z codes within the market. There was a greater level of utilization amongst providers than what I had expected, frankly. So that was quite exciting. So now, as we move into planning initiatives for the upcoming year, exploring the opportunity to incentivize. So there's a couple of initiatives that we'll probably deploy after the first of the year to increase and encourage that, increasing that utilization even further. So it was a good baseline and enough to help us plan out a communication plan and activities to help drive that even further. What I think is key, however, is that our providers are strapped, right? You're trying to run through visits as quickly as you can and be as comprehensive as you can be. So one of the things that we're truly looking at is, as we increase the utilization of Z codes amongst our providers, the coding of Z codes amongst our providers, I'm more interested at the then what. Right. So how do we then support our providers in addressing the issues surrounding those things? How can we become a better partner as a health plan in the care of our members, our providers, patients? How can we become more of a partner in that activity, right? And in getting folks to a more stabilized, balanced level of health. So that's kind of where our focus is moving forward into some of the initiatives that we have planned to launch here relatively soon.
Oh, great. That's such a teaser. Thanks for that.
We're so curious.
Well, because when you're saying like the then what, yeah, you're assessing and I'm taking the time to log, okay, there's unstable housing or maybe there's food insecurity. And I know a lot of other states are experimenting with this about then what happens there, what gets triggered, and under the authorities of a health plan, what can they, meaningfully do to impact that outcome? And there's a lot of different solutions out there, and directly supporting the services, streamlining the referral. So it sounds like you're headed in that direction, and there's more news to come that way. I know we work with, for example, North Carolina, that are using this type of health-related social assessment supported by the plan to then not only incentivize the assessment, but then also to potentially reimburse for those on-the-ground services to impact that health-related social need.
Exactly.
Great. Well, high five, the payers are represented here. And that's great. And it speaks to the diversity group. Are there other folks that would like to talk about the unique data sources that they've tapped into? If you recall from a presentation a few weeks ago, we actually mentioned some of the correctional data that we've on the ground in Camden that we've incorporated into educational data. A lot of data out there, getting access to it, meaningfully integrating it clinically. And that kind of takes us into the next place here about enabling your evaluation through not only different sources of data, but sharing data between organizations. And what does that really mean? Many organizations are doing this already, some better than others. Some of you may not be sharing, have access to data outside of your organization, which is fine. There's a lot of times it's a great place to start, even within your own program. Sometimes it's hard even to get information from other places in your health system, for example. I used to work at a large health system. We were on Epic. It was very hard to get to get data pulls out of my Epic platform, for example, but not impossible. So some of the considerations here, and I'm wondering if this is resonating with anybody, and Lauren, feel free to jump in. Certainly, this has been some of the active conversations that we've been involved with regionally here around what it means to begin a data sharing agreement, especially if we're thinking about an enriched evaluation methodology, if we're looking for varied data sets to inform what we're doing. So for example, if we need claims information on an individual, and especially, how could we potentially have access to that? If we want to look at their Medicaid claims, how would we begin to start that? And what are the organizations that have access to that information? So some of the issues here that stand out for us is, of course, there's the legal agreements that need to be in place. But one of the big issues are around the capabilities of organizations to manipulate the data, to store the data, to transfer the data that come up frequently, and then to even analyze it. Many of our organizations are, again, especially in this time, stretched pretty thin. So your ability to manage the data that you have access to is often a question as well. And we get into some of the specifics here. Lauren, I want to take a second, and I just want to scan the chat because I see it glowing here. If there's anything you would want to add.
No, I think this is great. We can help you with setting up the infrastructure in the agreements with each other. I think we should keep going and get into some of the questions.
Sure. And again, choosing measures, and we'll get into the frameworks around measurement that actually matter to not only your organization, that are tied to the design of your program, but also to the stakeholders that are involved. And those are pretty broad, that go everywhere from your organization to the individuals you're serving, to a larger community benefit, which is kind of the core of the complex care paradigm. So we'll walk through a 4 outcomes framework. Lauren, do you want to start here, and we'll move quickly through this?
Definitely. So looking at metrics in these 4 quadrants, we found to be very helpful and covers a broad range of stakeholders. So some metric related to cost, some related to utilization, some metric related to either patient satisfaction, provider satisfaction, client story, provider story, and then quality metrics. The what in those categories depends on what your end state model is and who your stakeholders are and what problem you're trying to solve. We have many different versions of that. We can help you choose it. But what we found is these 4 quadrants tend to hit all the needs of everyone. So your board may want you to lead with a patient story. Your CFO definitely wants you to lead with cost. Your community partners may want you to lead with quality improvement amongst organizations. Next slide, please. So some examples that we've used in the field with other partners. Next slide. The cost measure, so the savings, inpatient length of stay, total admissions, return on investment. I've gone very, very deep in cost. So all the way to how do you really look at variable costs, fixed costs, ED minutes and cost, length of stay. There's so many different cost measures. It really depends on how much rigor of support you have for data analysis and who your stakeholders are. Next slide. Utilization. So emergency utilization is very different than inpatient utilization and primary care utilization and community agency utilization. Depending on the problem you're trying to solve in your model, choosing the metric around utilization that matters most to your stakeholders and will show the impact of your program is key. You might reduce utilization, but not reduce cost. And that's why we recommend you track both, or you might reduce cost, but not utilization. This population is very complex. Some of them may start to have increased utilization and it's appropriate because they need disease management or they need more stabilization of the behavioral health. Some of them may have increased cost because they're accessing a level of care that they need for their disease management. So having both is really important to show the movement. So you can reduce costs by really good care coordination, even if utilization goes up. The admissions are shorter, the ED visits are shorter, so we can help you with that. Next
Lauren,
slide.
I just want to add here, if we think about the Camden example, we think about just the very limited amount of metrics that were applied, 180-day readmission rate, the likelihood of that was the main measure. And if you think about, well, we're probably, we did a lot of work connecting people to primary care and social services. We did a lot of work of trying to keep people out of the emergency room, connecting them to housing. And again, maybe there was an over focus on this metric that a lot of, that a lot of higher level powers that be kind of maybe tilted towards, but really missed the kind of complete story here. So we could have had other impacts, but I just want to bring that up as an example of how telling a story like this through a kind of a diverse framework like this can really help tell the whole story. So thanks for that, Lauren.
Great. Let's go to the next slide. So quality, I'm sure you're used to quality measures. Which ones matter? Again, depends on your design and your stakeholders. So really simple ones that often move in this population are, access to services, change in social determinant of health, resources, but also disease management. So GAD-7 and PHQ-9 in the population, hypertension, BMI, A1Cs. It really depends. And we don't recommend that you measure everything in the world, but choose a few targeted measures that matter to your model and your stakeholders.
Mm-hmm. And Lauren, can I add one on this one too? And some of the data sources for these we've left out because a lot of them are different, right? So when we talk about service connection rate, that would be something a lot of community-based organizations would be tracking, like who did we refer and connect you to, like a programmatic data set. Gap closure rate is normally used by, that's something that can be based in claims. when we start seeing some claims gaps in their HEDIS measures, which is data from the claims through their insurance to look for example, if someone had diabetes, do they have a diabetes test within the last 90 days, right? So the data sources for a lot of these vary and require that go beyond any individual organization.
And then the last one, I find it very valuable. You know, at the highest end, people are actually doing quality of life or satisfaction surveys. Most people don't do that overall outside of the, you know, the typical Press-Ganey type of HCAP surveys that are already done by organizations. But if you capture patient stories, a short video, provider stories, get quotes, give them the opportunity to write a letter or write their own story, it's so powerful. We encourage all our sites to do that. It really tells a story quickly and it translates a lot. And it's incredibly valuable with a lot of different audiences. Next slide.
I couldn't agree more, Lauren. And you're really a champion for this, and I think it's made a lot of difference. So I just want to applaud you. That really you foreground the experience of clients and providers, and I think it's a key strategy in our work, and it really helps to move things.
Jason, I turn it over to you.
All right, everybody, we're heading in. For those of you still on, and I see a good amount of folks still there, we're holding at about 24. So what are next steps here for complex care programs? And I've said the word emerging a lot because we do have to recognize this is a new and dynamic field. And we're all coming together and we're learning on this. There is no off-the-shelf playbook for all of this, right? Or off-the-shelf solution. So when it comes to metrics and evaluation, you need to get started and define an initial set of metrics with which you can start. And that will change over time. It'll be in pencil, but at least we can start. And we certainly work with one of the partners here regionally to start to get going that way. And think about a holistic design to your measurement where it accounts for cost, utilization, quality, and client and provider experience. I feel like I have that burned in my memory now, but it's such a useful framework to hit on, especially a lot of the stakeholders involved, the mission focused nature of the work that we're doing as well, the clinical component of the work that we do, the financial, potential financial impacts of these, again, very high need and often high cost cohorts. Next is discuss evaluation and reporting methodologies. How are you going to begin to, do you have the data sources that will allow you to perform this measurement? And how will you begin to start to report out on this? And a lot of times just getting the metrics defined, the data sources secured, and your first report run is a huge victory. And we work with groups, and I'm thinking about one of the groups that we're working with in the Northeast right now. Just to get to that spot has been several months just to get to creating a first report. And then from that, creating a realistic reporting timeline where your measurements, where you can update your measurements and you can confirm and set expectations with internal, external stakeholders about what that reporting timeline would be. So for example, for the group that we're working with in the Northeast, they haven't even gotten to this point yet because they're still trying to create, they're just trying to confirm on their initial set of measures and come up with a methodology around reporting that actually works for the organization. I'm just going to scan the chat here and we're going to go into, see if I'm missing anything. Okay. Let me make sure here. And Lauren, you can scan and let me know if I'm missing anything. It doesn't want to pop up for me.
I got you.
Okay, so this is the interactive component. This has actually been a really good group of, and we've had some good discussion. We have about 20 minutes left. So again, for the about 24 folks that are still on, thank you. Your time is seriously valuable. You're all doing awesome work and we want to hear from you now. This is a lot about the work that you are doing there in the St. Louis region. So we're gonna bring up the list of awesome interventions that are happening across. And I think, and Sally, I'm gonna cue you up here to begin to think about, we have a lot of awesome interventions happening, all different sponsors, different implementers, certainly different approaches to evaluation. and target population. So why don't we start there, Sally, if you want to kind of just do an overview and really focus this on the folks there in St. Louis.
Well, many of the people on the call are intimately involved with these initiatives, and sorry for the array of acronyms, but Project BEACN is the effort focusing on super utilizers of care funded by Missouri Foundation for Health that started in January, and we are the innovations of systems change are being implemented through the adult emergency room enhancement, which involves many community providers and 3 hospital systems. And then we have a clinical BEACN initiative. I can say that it's, it's funded by Mercy, but Mercy is going to have us, when we document things, listed as an anonymous donor. And they are going to subcontract for a clinical team that BEACN will help coordinate the efforts to use this complex care model to attend to some of their super utilizer patients. And then for about the past 10 years, we've been doing a family of initiatives under the auspices of hospital community linkages, an inpatient program, adult ERE for high utilizers, youth ERE, and EPIC, engaging patients in care coordination, focused on clients who present with an opioid use experience and present to an ER or first responders in ambulance. And then Barnes Hospital to Housing Initiative, which is funded by the Barnes Jewish Christian Hospital Foundation with a grant to the St. Patrick's Center, working on hospital patients who have significant needs, and housing is definitely a part of that, and trying to prioritize a housing first model in attending to those patients and getting them community-based care. Barnes Familiar Faces Initiative, which the hospital is leading themselves without external funding to do hotspotting, data-driven identification and care coordination across multiple disciplines within the hospital, and in the last year with ERE to attend to high utilizing patients. Healthy Housing, which is an initiative being spearheaded by Catholic Charities to gather a group of collaborating partners to attend to folks with chronic health conditions and housing vulnerabilities. And the SSM Behavioral Health Urgent Care, while this is not prioritizing high utilizers of hospital, it is focused on the behavioral health urgent care, providing an access point that is an alternative to ER or corrections, police taking people to, jail or the ER. And a new innovative access point with expedited transitions of care to community providers. So we aspire that some of the high utilizers of ERs will utilize this option instead to get expedited services. Healthcare Homes, a Department of Mental Health initiative to integrate primary care with community mental health centers and federally qualified health centers delivery of services, and disease management, which is patients who have generated high costs through Medicaid in the last 12 months have a mental health or substance use concern and are not connected to ongoing community care. And the community mental health centers and substance use providers are contracted to deliver outreach and engagement services. So this myriad, these are the primary efforts that I think really have prioritized folks with a behavioral health vulnerability and a high utilization pattern. And each of them are being very intentional in the metrics that they're gathering or planning together. So that's, we just wanted to say, how can we work together? How can we figure this out together and learn from each other? Jason, back to you.
Yeah, and Sally, that's a great question, and we'll pose it to the group here. I mean, you know, it's not uncommon, right, to have this type of arrangement where there's a lot of individual programs happening across a region. And I love what you've done here for cataloging them. And as you mentioned, when it comes to the target population, there are certainly parallels here. When it comes to the data sources and evaluations, there's probably parallels, but there's assets here with this group collectively that when brought together is kind of more powerful than the individual components, right? And I think that's what you're referring to. And how do we begin to organize ourselves to leverage the collective impact that is being had here? That is certainly, if you combine initiatives, you know, what are the possibilities here? So that's what's coming up for me, Lauren. And as you see this, you know, again, I think that's kind of core to this longer term project here of really building upon the work that's being done in, you know, local, like individually here, and, you know, to support this kind of ecosystem approach. Do you want to add anything else before we move through into some individual talk about indicators?
No, I was just going to say, I'm just so curious from the people on the call, if there's any sharing of indicators now that happens between programs, or any forum where people come together to talk about the outcomes of the programs.
That's a great question.
And you could type it in the chat. And Jason, you can go to the next slide.
Sure.
Thinking.
And Sally, a question for you as well. As you're deeply familiar with all these programs, I know BHN has that position as an organizing entity. You know, it's certainly something to recognize as, you know, thinking about shared metrics and shared data and assets and data resources as we begin to think about that kind of 360 view of the impact we're having. So to that, we do have a question. We were so curious. We were talking yesterday about for folks that are listening, what three indicators are really coming up for you at the moment? What come top of mind for you that you're trying to impact in your programs, or even in your role that you sit in at your organization? Because it's this that really kind of drives our decision making, and would love to hear from the participants on the call. I'm going to type in my three, and I see some chatting going on here, but we're super curious about that. And again, this can be everywhere from process to outcome measures, clinical to financial. Here, kind of prime everybody. We'd love to hear if there's certain, again, indicators, outcomes that for your program are just paramount for your organization. Thanks, Matt. Would love a little clarification there about Would you mind sharing a bit more? Because these are great terms here. I want to make sure the group gets it.
Yeah.
I appreciate.
No problem. Matt Mendrup, SSM Health. Yeah, to me, it's really, kind of the buzzword is transformative, but thinking thinking the ways we normally don't think to best serve patients, getting uncomfortable with certain things, again, thinking outside the box. Obviously, a reduction of cost obviously is always going to be a big one. And again, I think the linchpin with a lot of this stuff is sustainment. So we may get a lot of immediate, sort of people on board. And then as it, phases through the process, the sustainment piece is typically is a big linchpin. So how do we create a kind of a process or a transformative approach that has built-in sustainment strategies? Because what we don't want to do is put all this work into it and then 2 years down the road, okay, what happened, right? So leading indicators, matching kind of the lagging indicators to say, hey, here's what we're doing to drive these sustainment strategies to best serve these patients.
That's great. I love that. Nathan had a really interesting comment too. Let's go back. So well-being and looking at that. Nathan, would you be willing to say a little bit more about that?
Yeah, sure, just a little bit. So we have some programmatic outcomes that we look at, and they're kind of the standard measures that you would think about, reduction in PHQ-9 or GAD-7 scores, stuff like this. But then with the population that we serve, like in our psych rehabilitation services, trying to find an appropriate measure around life satisfaction or subjective happiness that kind of speaks to that idea of positive mental health being something distinct from just symptom remission, and finding a measure that's responsive as well. So,
is there anything you've come across that you really like? Because I'm so curious about that as well. We're always paying attention to that nationally.
Yeah, I mean, on the one hand, there's the recovery assessment scale that's been used a lot, but it's entirely too long for a sort of routine use. 41 items. It's been boiled down to 12, which is a little more user-friendly. But subjective happiness scale we've been trying that out, as well as a 5-item satisfaction with life scale. So still going through the evaluation on that.
That's great. Thank you so much.
Just want to add to that, Nathan, across the river in Alton at Centerstone, we were using something called a health and recovery capital, something that we had developed in-house. I'll see if I can share that as well with the group, but it definitely speaks to that kind of quality domain we were talking about and how we're doing the, accounting for the progress that's being made, especially with new and innovative measurement like this. A lot of times too, even in client self-report as well, and capturing that. We had an initiative at our community mental health center, again, right there in Illinois, across the river, that focused on measurement at every encounter. So we could begin to capture these things, whether it's your classic PHQ-9 or scales like that looked at wellness and happiness, or as I mentioned, health and recovery capital. So I think those are really important to consider and putting into our applying in a holistic evaluation outcome framework. I think there's some other comments here, Lauren. Are any jumping up for you?
Yeah, I saw Bailey. It was really interesting. The symptom reduction. I'm curious if you found any specific tool that you like to use, because we also look at that around the country, and wondered if you'd be willing to share anything about that.
Sure. So for kid clients, we use a tool called the Pediatric Symptoms Checklist. And what started us using that years back was our partnership with St. Louis County's Children's Service Fund, because that was a tool that they prescribed. They no longer prescribe it, but we've been using it. And so it's a good kind of general screening, but it doesn't really drill down specifically on any one type of symptoms based on a behavioral health disorder that someone has. So it's kind of a good first step, but then we encourage our clinicians to then have something to follow up if they, have higher scores of depression. What kind of depression screening are you doing with kids, and for other areas too? Another tool that we use for adults is the Brief Mood Survey by David Burns. If you ever read the Feeling Good Handbook or whatever it's called. But it is a really quick tool. It's 1 page and has 5 different subscales. So it's a really quick assessment that gives you a snapshot of a couple of different areas. It looks at depression, anxiety, suicide risk, anger, and then relationship satisfaction. It's nice that it calls out suicidal ideation, because sometimes someone might be caught off guard if they're asked that question in person, or it just gives you an additional way to make sure that you're screening for it. And there's only 2 questions related to that, but then you know that you're at least asking about it. And then for the depression and anxiety subscales, again, if they have any symptoms there, you could always follow up with something more specific to drill down more. But it's, I don't know, probably less than 20 questions total, and it's 1 side of a sheet. So it's really quick for people to fill out too, so they don't get as overwhelmed by a lot of forms that way.
That's great. Thank you so much.
Great, thanks so much.
It's really interesting.
So the rich discussion here, and thanks everyone. Sorry, as we move to conclude, and I think it also speaks to, as folks are volunteering, the different assessments that they're doing, the real value that's happening out there across our organizations, and being able to capture that and tell that story. So that was really useful feedback. We'll move forward here. We were talking, we had talked earlier about really thinking about the data sources that can really support your evaluations, which are super important. In the spirit of time, we don't have too much time for a lot of questions here. Want to get into some of the wrap up and next steps. Please chat us if you have any specific questions or comments or recommendations. It's been a great group and really productive conversation. Want to get into just some of the next steps for Project BEACN. Let our folks at BHN kind of close this out. For us, it's really it's been really helpful to anchor a lot of these discussions and presentations and what we're calling these site visits in the goals of the program, which focus on data and health IT sharing, financial sustainability, comprehensive assessment and collaboration between the organizations that are in the region, and of course our discussion here on metrics and evaluation. Sally, Melissa, do you want to add anything else? And then we can conclude. We have 1 slide about our upcoming virtual conference, but I want to give you guys a chance to close us out.
You're muted, Sally.
So to advance the complex care work through the MFH grant, we have an implementation work group, and we are open to additional members. But in the 4 areas of work that are outlined on the screen, we anticipate having some subgroups that will dive into these questions more methodically. So if any aspect of what you see, and particularly metrics and tracking of impact and indicators for continuous quality improvement, these are definitely conversations we'll keep going. But by virtue of you having been at this meeting, we'll keep you apprised of next gatherings and opportunities to share information. I know we will share the recommendations that are coming out of these site visits, and we'll figure out the opportunity to do that. Melissa, what else would you share?
Yes, so I agree with everything Sally mentioned. I was going to also mention the implementation work group. If anybody is interested in joining, please feel free to reach out to me. Also, I'd like to take a second and thank Lauren and Jason for all their hard work and everything over the past 5 weeks, actually. We've had a site visit every week, and I want to thank everyone as well for participating and making time out of their busy schedule to come and sit on Zoom with us. And so that's all I have to say, was to just say thank you to everyone. And I'm going to let Jason go ahead and briefly talk about this, and then you guys all have a great day.
Yeah, if you haven't spoken enough about complex care, if you haven't jumped into it, there's a national conversation happening. So,
Wait, there's more.
Yeah, there's more. So we run a national conference on complex care called Putting Care at the Center. It's virtual this year. Want to let everybody know about it. We'll send this out in the slides. You're all welcome. You're all doing the work. we're constantly sharing the work that's going on here with our other partners and saying how proud we are of all the work that's going on, great work that's going on in St. Louis. So we invite you to participate. You can see us at centering.care. And that's all we have. Thank everybody for their time and participation over these last few weeks. It's been really fun and thought-provoking, and we look forward to continuing to work with BHN and partners in the region. So keep up the good work. We'll be in touch.
And someday meeting you in person, hopefully soon. Have a great
Thanks,
afternoon.
everyone. Appreciate it.